Hey, Courage class. Welcome to the podcast. My name is Lindsay Kwok-Hugh, and I am the creator and host of this podcast. Look, I know that you are incredibly busy, so anytime that I can get someone to sit down with me for 45 to 60 minutes of their day, I want to make sure that I am over-delivering on the content that I share with you. In addition to that, if you like what you heard on the podcast, can I ask you for a favor? Can you subscribe to the newsletter? I'll leave the link below. This is an opportunity to keep in touch on a weekly basis, and I like to think of it as a love letter in support of you. Thanks so much for being here. I truly appreciate the time that you spend to listen to Courage Class. Have a great week. It's no secret, I am a huge fan of therapy. It's one of the most important ways that I've supported my own growth over the years. And this is why Courage Class is so excited to partner with Anise Health this month, an AAPI-focused online therapy platform that I have personally used. And I genuinely loved my experience and felt immediately that the therapist I was matched with understood where I was coming from. She understood my goal for the session, and somehow I laughed and I cried as we spent the entire time talking about my struggle with perfectionism. This to me is the hallmark of culturally attuned care. She understood the history of perfectionism in the Asian American community as a woman and knew exactly how to weave that in and out of the conversation without judgment of me. I take my mental well-being very seriously and want nothing but the best for you guys. If therapy is something you're considering, Anise is offering a free intake session this month. Just use my code COURAGEMAY, COURAGEMAY, to get matched with a therapist who understands your lived experience. Hey, Courage class. Dr. Somi Javaid is a force in women's healthcare, a board-certified OBGYN, TEDx speaker, and the visionary founder of HerMD, the groundbreaking healthcare platform redefining menopause, sexual health, and gynecology care for women everywhere. As one of the few women of color to secure venture capital funding in the U.S., she's not just building a company, she's leading a revolution. From national media features in Forbes and Vogue to the documentary The M Factor, Dr. Somi is breaking stigmas, training the next generation of providers, and transforming the future of women's health with relentless advocacy, innovation, and heart. Let's listen in. All right, Dr. Somi, I want to thank you so much for taking time out of your busy schedule. Now, my first question for you is for the female for the female listener who feels fine on paper but not like themselves. How could their life improve if they understood what's happening to them right now in this moment and they actually got the right care?
Oh my God, that's the first thing that women share with me when they're talking about hormonal transitions is that if they had just been prepared or just been told or had education or resources, they wouldn't have felt like they were hit by a Mack truck because that's how they describe it. And then because they have these symptoms and no one has told them what is going on, they feel like they're crazy. That these are words they have used to describe themselves, that they're out of control. And then they become very fearful because they feel like that this is the way they're going to be for the rest of their lives.
Yeah. No, that personally resonates. And that's certainly the way in which some of my friends have talked about this period in their life. When most people hear the word menopause, they think of, or I should say, I think of a singular moment. It's like being hit by the Mack truck, and then like it sort of extends and extends and extends. What's the biggest misconception about what this actually is?
The end.
The end.
Women think it's the end, and I think of it as I want people to reframe it and say that if we're lucky to live long enough, we're all going to go through menopause. And it's interesting that you say that because it's all semantics. Menopause is technically a singular day. It is the day you have gone 12 months without a cycle. But there's women you can't use that definition because of partial hysterectomy or ablation or whatever. Okay. And then the rest of our life is postmenopausal. So we spend 40% of our lives either perimenopausal, menopausal, or postmenopausal. But technically, medically speaking, menopause is a singular day, and then the rest of your life you spend in postmenopause. Does that mean you're symptomatic every single day? No. Does it mean the end? No, it is a time where my patients and my peers and colleagues are creating and starting businesses and pivoting and truly finding themselves. It's that perimenopause that is often described as a zone of chaos, that I think if we give women a plan and education and options and bodily autonomy, that the path can be very smooth as opposed to what it is right now.
Absolutely. Would you be willing to clarify for us what is the medical definition of perimenopause and what is menopause and then what is postmenopause?
Yeah, so the average age of menopause in the United States is 51 and a half. It's the singular day where you've gone 12 consecutive months without menses. For women who have had a partial hysterectomy, still have their ovaries, have had an ablation, and maybe are unsure, there are blood tests that we can do. We can measure an FSH, a follicle stimulating hormone, technically on 2 different occasions, and check your estradiol level. Recommended is blood or serum testing that insurance will cover. Perimenopause is the 7 to 10 years preceding menopause. There are more and more femtech options that are coming out there that give women collated data that tell you, what's happening to your estrogen, your progesterone, your testosterone. And there are some direct-to-consumer tests for perimenopause, but medically speaking, there is not a singular test that says, yes, you are perimenopausal. It is really a collection of symptoms, head to toe.
Okay.
Vaginal dryness, hot flashes, insomnia, mood changes with your cycle. So perimenopause and menopause are like twin sisters. The only difference is in menopause, there should not be any bleeding. In perimenopause, there is still menstruation.
But do you still have symptoms in menopause?
A lot of women are very symptomatic. And then postmenopause is, for the rest of your life. And then there are invisible symptoms. So a lot of women will say to me, well, I don't need treatment. I'm not having hot flashes. I'm sleeping well. My mood is great. But what we don't realize is I call them the 3 biggest invisible symptoms of menopause, and it's pretty scary. There are brain changes that are happening aside from the mood changes that are actually directly a result of the estrogen deprivation in the brain. And what do I mean by that? Estrogen helps us optimize glucose as fuel. Okay. And what happens when we don't optimize using that fuel? The brain goes, oh, I'm going to use myself as fuel. So you start to see shrinking in the brain and markers associated with dementia, separate and distinct from aging. And so, yes, we think of dementia as a disease of old age, but actually changes that start to occur in the brain start in midlife. And some of them are directly attributable to lower estrogen levels. So dementia or brain health. And number 2 is cardiovascular health. We start to see cardiovascular changes as women go into menopause, and our risk of cardiovascular disease increases. And the third thing is bone health. We see some of the biggest bone loss in perimenopause, and in the years the last couple of years of perimenopause going into menopause, in the first few years of menopause. And women don't know this because it's not like you see it until you have a fracture. Oh, wow. And we're not recommending DEXA scans until women are 65. Women aren't going into menopause at 65.
Yeah.
So I tell women, or I recommend hormones to protect your bone, brain, and heart, in addition to improving quality of life.
No kidding. So you just said that these are invisible symptoms. And so there's no way for us to gauge or anything that we can do essentially until that moment of having a bone fracture.
No, we're just waiting for things to happen. And that's why you and I are talking, because I'm not about waiting or chasing
Yeah.
disease.
Yeah.
I'm about preventing it. So
Absolutely.
you can ask for a DEXA scan as you are in perimenopause, and
I'm
I would
sorry, what's a
highly recommend it.
DEXA scan?
DEXA scan is a scan that looks for osteopenia, bone thinning, or bone loss.
Okay.
And people will say, well, Dr. Javaid, it's not covered by my insurance until I'm, 65. Well, that makes me really damn mad. It's true, it isn't. But I will tell you, a DEXA scan is FSA, HSA eligible, and usually now in most states runs about $150. And I have taken care of women for 2 decades. I know what we spend on our hair and our nails and our children's soccer cleats.
Right.
And so this is the one test that I would say if your insurance will not cover because you don't have a major risk factor, then I would actually tell women get that. And then as far as your heart health, no, there are things that you can do. Lipid panel. And then if it is abnormal, there's an advanced lipid panel that checks things like lipo A and ApoB, and then there's a coronary calcium test that we can do, which is a CT scan. Same thing, insurance doesn't cover it, but it's $95 out of pocket. So they're getting a VO2 max tested. You have to go to a doctor's office to do that. Although there are some, I think, at-home devices now that may be able to estimate that, and that can tell you your heart and lung health. But no, there are things that you can do. Now, I'm not telling you to get a brain scan, but there are definitely things that you can do. Like one of them is take hormones.
Okay.
But there are a lot of other things that we can do in our life, meditation and sleep and eat clean and avoid things that cause inflammation in the body. But there are definitely prevention. And we know that hormone therapy does reduce our risk of cardiovascular disease, stroke, and breast cancer. A study was just released this past year by 60%. So reduction in cardiovascular disease, stroke, and breast cancer if we start hormone therapy in perimenopause. Yet no major medical organization or society tells doctors to prescribe hormone therapy in perimenopause.
Wow, this is incredible. As a patient, do I go in asking for these tests, or is this offered to me?
It was offered at HerMD. So unfortunately, a lot of this type of medicine is concierge, where they're checking body composition and VO2 max, and, they're offering you these advanced cardiovascular screenings. So no, this is why you and I have these conversations, because I want people who are listening to know that a lot of these tests are accessible. You can ask for them. So even though, like, for example, the coronary calcium test,
Yeah.
even though it is out of pocket, you still need a doctor's order. So you still have to ask your doctor for it.
I see.
But I don't know any doctors that would say no. Like, why do you want that? So most doctors were like, oh, yeah, that's a great idea. It's just, I was that doctor in our traditional healthcare system that was trying to see patients for 5 to 7 minutes. You're supposed to interview the patient, examine them, talk to them about their risks, benefits, alternatives, send in all their prescriptions, type it all up in a nice note, and get that done in 7 minutes?
Yeah. Yeah. Like that's
No.
not even possible. I'm obviously
No.
not a physician, and no, that's not even possible.
No, so that's why you hear about medical tourism where people are going, to Turkey, or they're doing these head to toe MRIs and paying out of pocket because we're not screening for, 50 different types of cancers that this head to toe, test can pick up, this screening. And there's a blood test to check for cancer markers. There's so much innovation that is out there. It's just we don't have time to integrate it and teach our patients about it in our everyday 5 to 7 minute visits. It's impossible.
Do you recommend, I mean, we're going to get into HerMD and the incredible platform that it is. Do you recommend, you just said that a lot of these tests, you have to go through maybe a concierge.
Mm-hmm.
Do you recommend that people pursue that pathway? I'm just wondering, to what extent can I rely now on my doctor?
No, I don't recommend.
Yeah.
I'm not recommending concierge. If you have the ability to afford a concierge doctor, then by all means, I have great colleagues and friends who are concierge, but there are a lot of people who can't afford that type of care. And so you kind of have to do the homework for yourself. But the benefit is your life. And so, and nobody knows your body better than you. And this is where I empower
Yeah.
women and I want them to be, if there's one take home message today, it's be the CEO of your own healthcare.
Mm,
And so women tend to be the CEOs of their families, but they kind of forget about themselves and put
yeah.
themselves on the back burner. But no, I think you need to learn about these tests, do your own research and then decide and then bring them up to your doctor and ask for orders for all of these tests. I don't have a concierge doctor, but I get a coronary calcium test every year. I have not gotten a DEXA scan yet, but I'm going to. I'm 50 years young.
Okay.
I got my colonoscopy screening early, so I do a breast MRI because it's more accurate than a mammogram, and I do a screening breast MRI. I also tell women to make sure you know your Tyrer-Cuzick score. I don't know if you ever saw the article. See,
No,
Olivia
no.
Munn was like, my
Oh, yes.
doctor, yeah, like the one test. I've been doing Tyrer-Cuzick scores on women for 2 decades. Less than 5% of OBGYNs check. It is literally a questionnaire you fill out, and it tells you two pieces of information. Do you qualify for genetic testing?
Mm,
And then what is your lifetime risk of developing breast cancer? Because if your lifetime risk is greater than 20%, your insurance will cover a full-blown breast MRI versus a
oh,
screen versus a mammogram, 2 clinical breast exams per year plus a mammogram, because you're considered high risk. The average risk for a woman in the United States is about 11, 12%. And then there's women like me who have dense breasts, and I have 16%. So insurance won't cover my MRI, but I know my mammogram's not enough. And so what do? There's something called a screening breast MRI
okay.
that a woman can pay for out of pocket. You still need an order. That's what makes me so mad, is that you still need an order,
Okay.
but it's less. They take less cuts or less images than you would a full blown breast MRI. But in most states, it's $275 to $350 out of pocket. And you best bet I do it
Yeah.
because I'm of elevated risk compared to the average woman, but I don't meet the 20% criteria for
Yeah. For
insurance.
insurance. Oh,
Yeah, so that's what I do. And so I don't have a concierge doctor, but it was a lot of practicing medicine, learning this, but these are the tools I want women to have because no, good, excellent healthcare is not just for affluent people. It should be for everyone. It
yeah.
should be accessible.
Yeah,
Yeah.
yeah. And that's why we love you so much on this podcast in preparation for this particular conversation, Dr. Somi. I'm thinking right now, just in real time, I think we might go through the transcript and pull all of the recommended out of
Yeah.
pocket opportunities, and we'll post them within your show notes and on the website. Dr. Somi, I'm wondering if we could talk more granularly about Asian American women, because at Courage Class, we speak directly to this particular demographic. And I'm curious to know from you and your work, do AANHPI, Asian American women, are we more likely to have particular symptoms? For example, hot flashes are something that I have personally not experienced. Not that my experience is, of course, illustrative of the entire population.
Less likely. But here's the deal. The studies and the data that were done only included white women, black women, Hispanic women, and then when we're talking about Asian women, Chinese and Japanese women. So those are the largest subsets of, so it did not cover everybody who would fall ethnically under that umbrella. And so actually, they reported the lowest incidence of hot flashes,
Mhm.
but they think that some of it is culturally normalizing the abnormal.
Okay.
And then also maybe a distrust of the medical system.
Mm.
And then also discomfort with speaking about such things with a medical provider.
Sure.
So it's likely underreported. But we don't know for sure. You know this because women weren't mandated to be included in clinical research trials
It's wild.
until
Yeah.
1993.
Yeah.
So I would say limited data because it doesn't include everyone who would fall under that cultural or ethnic umbrella.
Mhm.
And I would say I think they think there's limitations and it's underreported because of some of those barriers to care that I explained.
Oh my gosh, yeah. No, look, can we talk about cultural norms? I'm curious to know, how do cultural norms in Asian American communities shape how women experience and talk about menopause?
Yeah, so I mean, they're less likely to report it.
Yes.
There's also different symptom framing and expression of that, where they may not say that it's a hot flash or a night sweat, but might just say that they feel warm or, uncomfortable, but not enough to report it.
I see.
Now, there is also another theory is that Asian women have a diet and nutrition, because remember, we talked about the holistic approach, and they're less likely to intake foods that are triggering of hot flashes and some of the menopausal symptoms. Because an important takeaway was data that we do have is that when Asian women adopted a purely Western diet, not meaning they had a meal or two, then guess what happened to their rate of hot flashes?
Yes. Yes, it went up. Yep.
They went up.
Yeah.
So they think that some of the cultural differences that you and I are talking about were actually beneficial because the diet is actually superior to what we consider a traditional Western diet.
I see. Their cultural diet is less likely to sort of trigger that. I see. Okay.
Yeah.
That makes
Yeah.
a lot of sense. It makes it because
Yes.
we eat what the American diet is, what, like fried food and
Fried food,
yeah.
processed foods, inflammatory. So a lot of foods that cause a lot of inflammation.
Mm-hmm.
Caffeine and inflammation are known triggers for hot flashes.
Okay. That's good to know. That's excellent. Thank you for sharing that, Dr. Somi. I would love to transition into HerMD. You are the successfully exited founder and operator of HerMD. And I want to also mention, because we love women of color in particular, raising money. You were one of 0.4% of women of
Yeah.
color to have raised money to grow your business, which is incredible in it of itself. Congratulations on that. Could you share with listeners what exactly is HerMD and why did you decide to build HerMD?
So I nearly lost my mother when she was only 45 years old, due to our very broken healthcare system. She had left arm pain, shortness of breath, chest pain, and her doctors told her it was too much caffeine. Her doctors told her children were stressing her out. So I decided, she finally underwent emergent quadruple bypass surgery. And when the surgeon came out, he said if her heart attack would have come, she would not have survived because her widowmaker, or the LAD, the main vessel in the heart, was 95% occluded. And so I was pre-med at Northwestern at the time, and I was like going back and forth between Chicago and coming home to help take care of my mom. I was like, that was my aha moment. It was, I'm gonna, be an advocate for women. And then fast forward through residency and medical school, and I got my first big girl job, and I was seeing 50 patients a day. And so my idealistic face got a giant smack. I wasn't going to the bathroom or eating, let alone advocating for anybody. And so I'm listening to stories of cancer survivors and women in perimenopause and menopause, and I've done hysterectomies and now I've fixed their bleeding, but now they're hot flashing and they have no libido and they're not sleeping and they have brain fog and they feel like they can't work anymore. And I felt like a complete and utter failure because I had almost zero training in menopause. And so when the timing was right, I came home and I told my husband, I said, I am either going to stay home and raise these babies, or I'm going to practice medicine the way that I intended. And he was like, good God, girl, you will sell bananas if you stay home. And so I literally cashed in my 401k, my life savings. I bought a building
Wow.
and started a company that was provider and patient centric with longer appointment times and specialized in advanced gynecology, menopause, and sexual health care. And I did this 10 years ago. I mean, this was before MIDI, before Maven,
Yeah.
before, and I did it in Cincinnati, Ohio.
Yeah.
People were like, "You're nuts." And then we witnessed women from 35 states and 3 countries coming to Cincinnati, Ohio. Friend, we are not known for medical tourism here, okay? And then we decided to fundraise because I wanted to, it broke my heart. When I saw the map, the heat map of where women were coming from, at first I was like, oh, this is amazing. And then I was like, no, this is so sad. This should be accessible. Why are they having to come travel to get this type of care? And so we decided to fundraise. They told me as a minority woman from the Midwest that I had a 0.37% chance of raising any venture capital because I didn't know any of the venture, community.
Sure.
And to date, raised $40 million as a minority woman from the Midwest in her 40s. Yeah.
Wow.
Yeah. And so now, yes, we scaled and then we were acquired last year and became part of Joy and Blokes and now are part of a national platform of care. And so I'm an exited founder. And then the other, I don't know if you know this part, but we have a dual exit because I had set up a educational platform within the company because right now there's one trained provider for every 32,000 patients. And this initially wasn't supposed to be outward facing. It was just to train HerMD doctors. But then it was like, why aren't we sharing once we sold, the telehealth portion of the company? And so we just successfully exited the academic educational academy platform, which is now
Incredible.
being used to fix that educational gap with providers.
That's incredible. Are you talking about the HerMD University? I heard you talking
Yeah.
about that.
Yeah. HerMD University
Yes.
Academy. It's been used interchangeably. Yes.
Okay.
Yes.
Okay. And that's being taught, is it being taught across medical schools or is it like an additional certification? How do I go
So,
find a doctor that has that sort of stamp of approval or training,
so
not even stamp of approval, training?
Encore Vita is the company that bought us or bought the academic platform, and they are starting in phases. So right now they're starting in medical spa. So with medical spas and aesthetic providers, with derms and plastic surgeons, who women are, you would like think what, but we saw this too when women want hormones, they want to look and feel better. And so they're starting there. And then the eventual goal is to go into private practices, hospitals, and really, it's not to go to medical schools and residencies because we're starting to see that incorporated in curriculum. The goal is what do we do with this population of providers now? Because the medical students aren't going to be out for a decade. By the time they go through 4 years of medical school and then 4 years of training.
Yeah.
So that's great. The schools have time. This is like, what do we do with the providers now to get them on board? Because we learned that sending them to a course and then letting them come back is not enough.
Okay.
And so this is a whole digitized, interactive academic platform for them to help them. And we witnessed at HerMD, we pulled outcomes posters and we saw that our outcomes were superior to the status quo and that no matter where the providers were in their training, whether they were an MP or an MD, whether they were in their 20s or 60s, that we were able to convert them to our methodology or what we called algorithms of care.
That's incredible. Well, congratulations on that. I mean, you talk about superior outcomes, and I would love to hear from you. For those of us who are accustomed to not having our needs centered in a conversation, if I go to HerMD, if I come to a doctor who is trained with the content from HerMD University, let's say, what can I expect to experience inside of that context? And how does that contrast to, I always think that my needs are being centered maybe inside of my doctor's appointment.
God, we had a box of Kleenex in every room because women would just cry. and cry and cry and cry. And it was the one simple sentence is, it's the first time they ever felt heard.
Oh my gosh, yeah.
And so you'll have a provider who has extra time to listen to you, so longer appointment times. Someone who has that level of training, so will really break down your symptoms. And then not only talk to you about hormones, but be up to date on the data of today, not the myth and fear of yesteryear, but also, other non-hormonal prescription options, direct to consumer curated products, pelvic floor physical therapy, counseling, the whole biopsychosocial approach. And they will meet you where you are or where you want to be. So, and be able to answer your questions in a data-driven way. You won't be dismissed and you will finally feel visible and heard. And so that is what I say. People are blown away. We would read reviews and it was like, I got more information in that visit than I did in 2 decades of going to see a doctor. And you will learn how to prevent disease rather than chase it and be given with all of that knowledge and information.
Yeah, which is incredible. And also, like, I have a big lump in my throat. I feel like just listening to you describe the women, I feel like I can almost relate to that. I feel like so many women in our Courage Class community can unfortunately relate to that feeling of not being heard. And to be able to experience that in a doctor's office, I can't even tell you, like, probably what a relief that must be for so many of your patients.
That, and I think it's the first time you'll be asked about your sexual health beyond contraception, infection, and fertility.
What do you mean by
People
that?
are shocked when we really get into libido, arousal, sexual pain, orgasm, satisfaction. They're like, wait, there's options for women? And we're like, yes, there are options for women.
Yeah,
And
yeah,
they're amazed. And they're no longer afraid by the time they leave of perimenopause, menopause, or whatever is going on with them. And they're not afraid of hormones because that is another huge mission of mine. I do not want women, even if they opt not to have hormones, I believe in bodily autonomy. That's great. As long as you're making that decision based on data and not myth, I'm great with that.
yeah,
But they're no longer afraid of the substances that their bodies are producing. And that's what we've really done to women. We've done a lot of harm to
yeah,
women by
yeah.
making them afraid of what we naturally produce.
Could you talk a little bit about hormones and you mentioned the myth. What is
Mhm.
the myth around?
That if you're not symptomatic, that you don't need hormones. And we talked about why. Hormones can reduce your risk of all-cause dementia, cardiovascular disease, stroke, can help promote longevity. That testosterone is a male hormone. That hormones cause cancer.
Yeah,
That WHI study was very, very flawed.
yeah.
And overnight, we watched hormone use go down to the single digits. And then what we saw skyrocket were prescriptions for insomnia medication and anxiety medication and antidepressants. And we caused a lot of women to have unnecessary hospitalizations, urinary tract infections, fractures, and death. Like if anyone ever says to me, well, it won't kill her. No, menopause can actually kill you.
Oh my God.
And so the FDA director gave a statement saying that we withheld from women one of the most powerful preventative resources, hormones, that we have in our arsenal because we stuck a black box warning on vaginal product. And do you know there was not a singular data set that supported any of the claims that vaginal hormones could do that? And we slapped a systemic, not great data outcome, the WHI, on a localized hormone product.
Yeah.
Yeah.
Which is insane, which is incredible to me.
And so why the WHI, just quickly, take home, we studied women who were 70 to 79. We're not going to prevent disease in 70 to 79-year-olds. And that's not the typical, population that you're treating as women are going into menopause. So they likely already had pre-existing disease. We only studied an oral formulation of medication. So oral estrogens go through the liver, and they are the only type that it really has been shown to increase our risk of blood clot, heart attack, or stroke because our clotting factors are made in our liver. So if you have a transdermal, meaning a patch, a spray, a gel, a ring, we don't see that same risk. I think the cure rate of breast cancer is about 94% in this country. And so in the estrogen only arm, even with older patients, even with the oral medication, and it also wasn't bioidentical. It was a conjugated medication, meaning it had about 17 different molecules of estrogen in it. Even with all of that badness, the estrogen only arm still showed a reduction in the risk of breast cancer, all-cause mortality, and the women who got breast cancer on the estrogen arm had a reduced risk of dying from that breast cancer. It was only the estrogen plus progesterone arm that showed a modest increase in breast cancer, and we don't even use that progesterone. If you can use a much cleaner bioidentical form of progesterone that also mitigates that risk. So flawed study, overstated claims, and estrogen use and hormone use dropped overnight.
Wow. That is incredible to hear you just lay that out too. I've heard of the study before, but to hear you share the data in such an explicit way and then talk about the drop and talk about the benefits of hormones, I think is just incredible to hear you talk about. Dr. Somi, let's say we don't have access to HerMD. How can women advocate for themselves if they feel their concerns are being brushed off in a typical medical office? Do I go in with that legion of, tests that you recommended earlier in our conversation? What would you recommend?
So I would recommend number one, try to find someone who specializes in menopause and perimenopause. Menopause Society has a locator. I think Tamsin Fadal, who's got a lot of followers, Mary Claire Haver, they all have resources on how you can find a provider who's trained. So it's really, but let's say some women still come to me and say, hey, they're still not in my network, Dr. Javaid. I have to go to my local, OBGYN or my local family practice doctor or internist. Because it's not only OBGYNs who are trained. I would say do not expect this to be done in your annual. Number one, insurance will not cover it. Number two, your provider will not have the time, and your provider doesn't choose their schedule. It's chosen for them. So make a separate appointment to discuss your symptoms. Number three, even that, prioritize. Is it your lack of sleep? Is it your lack of sex drive? Is it your vaginal dryness? Is it your mood changes? Like really pick your top two or three symptoms that are bothering you. Be willing to come back. And be patient. Usually once a patient is on a treatment modality, then it goes a lot quicker. But that initial I tell people, may take 2 or 3 visits to get there. But don't try to bargain with someone. If they don't believe in hormones or they're not trained, you really need to leave. It's a recipe for exhaustion on both parts. Yeah.
That's good to know. That's good to know that they can expect that sort of time frame to get any sort of treatment sort of up off the ground, and to know, like you said, don't bargain with your physician. So just cut your losses.
Cut your losses.
Yeah. Cut your
Some
losses.
cost.
Your time.
Some cost.
Absolutely. Dr. Somi, as we come to the conclusion of this discussion, could you share with us what is one small step that you would want someone to take this week if they think they might be in perimenopause?
I want them to read about it. So whether it is, or to learn about it. So if you are a visual learner, so I would watch a menopause documentary. There's called the M Factor. Yes. There's M2 on perimenopause. So if you are someone, there's a Balance docuseries, I think on Amazon. I can't remember. Pick up a book if you want to read about it. Mary Claire Haver's book is great. Tamsin Fadal, Naomi Watts wrote a great book, dare I say it. A book or listen to a podcast. The Disruptor is a great one.
Yes.
Kelly Casperson's got a great one. You're Not Broken. I think figure out a way to learn, or social media, there are all these great doctors out there who are teaching and training, and giving out free information. So arm yourself with the education that we have not been given. And the better prepared you are to understand what is going on with you, you will get the maximal benefit out of your doctor or your provider's appointment.
Excellent. Thank you. Thank you for saying that. Is there anything that I didn't ask you today that maybe I that you would want to share with our audience?
Yes, there is. There are actually FDA approved medications for low sex drive. So there's only two out there, but one is called Addyi and the other one is called Vyleesi. And for those listening who are not into hormones, that's fine. These are both non-hormonal. So if you are struggling with your sexual life, and you are facing losing a marriage or a relationship or your confidence, you don't have to just live that way. There are actually FDA approved insurance covered options for women who are struggling with their sex drive.
Is this like the female equivalent to Viagra to some degree?
One is and one isn't. And the only reason I say that is Addyi is every night, regardless of your intention to be intimate or not.
Okay.
Works on neurochemistry in the brain. It's fascinating. So it's not an on-demand. So basically, the 3 clinical endpoints were it increased desire, increased number of sexually satisfying events, so eliminating the checking the box sex or I love him or her sex, and then decreasing the distress associated with your sex drive not being where it used to be or where you want it to be. There is an injection called Vyleesi that is on demand. So you inject yourself about 45 minutes before you want to be intimate. And the effect lasts about 12 to 16 hours. Also works on neurotransmitters in the brain, also non-hormonal. And so generally women pick one or the other. I do joke that women are much more likely to inject themselves to lose weight with the GLP-1 or their face with Botox. And they always look at me like, you want me to inject myself? So I want to have sex. And they don't like the pressure of the on-demand. And that's very, very normal behavior too. Men are much more likely to have spontaneous desire. Women are much more likely to have responsive desire. Women don't like to plan sex. Men have no problem popping a Viagra or Cialis. But currently in this country, less than 5% of providers know about Addyi, although there is the pink pill film or documentary out now. Less than 1% of women know about Addyi. And when I go into a room and I ask about Viagra, like you just mentioned, every woman raises her hand and they know what that is. When I say, do you know what Addyi is? It's like a handful.
Wow, that's incredible. So this is normal then to lose your sex drive, or it's a physiological effect?
I don't want to say normal. It's common.
It's common.
Very, very common. And it is very distressing, particularly to those people who are in relationships and feel like they're losing their minds. They're like, I love my partner. I could just care less about intimacy. And that was a big, portion of our relationship. And that was important to us. I had a man come up to me after one of my talks and said, oh my God, I think I lost my marriage because of menopause, specifically from GSM, genital urinary syndrome of menopause. She was having vaginal pain and dryness, but she didn't tell him. She just kept rejecting him. Because she didn't want to be in pain. Like, who wants to do something that hurts?
Absolutely.
And their doctor didn't give him a diagnosis, and they ended up divorcing, and because he took it as rejection. And to me, that makes me think about it. That was preventable. It was preventable.
Yeah. That's incredible. Dr. Somi, one more question. What do you courageously aspire for in your work and in your personal life?
Ooh, I think those are two different answers. I used to say that I want to revolutionize women's healthcare. And then I realized that there's a lot of things that need to be done for that. And that's a big task for one person to take on. So for me, I believe in legacy. If you have even helped or changed one person, whether it's a doctor that I've changed the way they practice or a patient's life, then I've left medicine a little bit better than where it was, and for the next generations made it easier. Personally, I would say freedom. I want to wake up every day being able to be where my feet are, literally and figuratively, and spend my time in a way that fulfills myself and others.
Beautifully
Yeah.
said. I want to thank you so much for this conversation. So much incredible information. I want to encourage everyone to go check out HerMD. It's an incredible platform. And just personally, from a mom to another mom, I just want to thank you so much for being such an incredible example for my daughter and for all of the daughters in our community, because you saw a problem and you didn't just talk about the problem, you went out and fucking did something about the problem. And you raise venture capital money. Again, we can just sit with that in and of itself. So I just want to thank you for the spirit and the person that you are, and for the life that you are breathing into this very important conversation for 50% of the global population. Thank you so much. Thank you.
Thank you. Thank you for having me.
Yeah.
This was a great conversation.
Thanks for joining me on this episode of Courage Class. I hope today's conversation gave you a little encouragement and inspiration. If you enjoyed it, please like and subscribe so you never miss an episode. And for extra motivation, tools, and behind-the-scenes content, sign up for my newsletter. I'd love to share with you more there. See you next time.